this topic has been on my mind for a while, since September, because the FDA came out and linked a folic acid deficiency to autism. And that created no small controversy in the medical world, right? And I read a lot about this, followed a lot of the talking heads. The reason it created a controversy is that, like dementia, autism is a multi-factor illness or disease state. It's not caused by one thing. So the people who are grumpy with this announcement were grumpy because they said, hey, we're going to give false hope to people. We're going to tell them that if they just replace folic acid in specific forms in their autistic children, that they're going to get better. And we should not convey that. That's the same argument I've heard in dementia, that people who get grumpy about dementia, they will criticize what I do because they'll say you should never give false hope that people who could overcome dementia or get better from dementia. So I can't believe you would do that. And so it really resonated with me to read the people who argued with, why would you talk about the link of folic acid and autism? Because I've heard that for 10 years when it comes to dementia. And my response, in fact, I did a social media post. One of my dear friends practices medicine, and she was really grumpy on her social media post. I can't believe the FDA would do this. What a joke. And then they badmouthed Tylenol. What about women who get a fever? And so I took the opportunity to say, hey, wait a minute. You practice mental health. You prescribe mental health medicines all day long. And you and I both know there's side effects to those drugs. Does that mean you never use them? Does that mean they're dangerous? Does that mean we would never recommend any mental health medicine because there's a potential for a side effect? And she said, no. And I said, of course not. So why wouldn't we say, hey, Tylenol has a potential side effect? You take it, you weigh the risks and benefits, but why would we disparage it? Because someday I'm going to have grandkids, and my grandkids are all going to have a risk of autism because the prevalence is growing like a weed. Currently in California, 1 in 13 kids have autism. 1 in 13 births have autism. And when I was growing up in the late 70s and early 80s, I don't remember a child with autism in my elementary school class. It was unheard of, right? But now it's very common. And so I'm grateful that we're starting to link some of these challenges together. And because folic acid deficiency was one of the links to autism, I thought, okay, I'm going to do a deep dive with my cognitive group, my academics, politely, you nerds out there that are actually interested in folic acid. I'm going to give a deep dive and talk about what the benefits are. So here we go. I'm going to share my screen and we will get busy. All right. And I'm going to change my camera here. All right, so as you can see, the title is The Role of Folic Acid in Neurological Diseases. And I always try to figure out what's a good name for something. I don't know if that's a good name, but a good title. Maybe I should say, what's the role of folic acid in your brain health? When you leave today, I want you to leave with an assurance that you need a very high level of folic acid if you want to preserve your brain health over a lifetime. And it doesn't matter where you're at in that lifetime. Pregnant mothers are told to take a multivitamin with high levels of folic acid because why? It prevents neural tube defects in a developing fetus. So we know that you need folic acid from embryonic development until we get buried in a grave. We need it for the whole span of the lifetime, and I hope you leave my presentation today and say, oh yes, I want to make sure I pay attention to that. Folic acid deficiency is linked to several major problems. So I'm going to start my presentation to say, if you have a folic acid deficiency, here's your risks. Number one, you'll get anemic. Folic acid is required to make a good, healthy red blood cell. So the symptoms of that, if you're always fatigued, if you're totally exhausted and you're pale, maybe you've got a form of anemia related to folic acid. It's called megaloblastic anemia. Okay, I'll talk more about that later. A developing baby has to develop brain tissue, and the brain tissue develops from something that are called neural tubes. So we call these defects in neural tube development or neural tube defects, and it's related to things like spina bifida, or you're born without a brain. That's called anencephaly, or some sort of encephalopathy, right? These are problems that happen with low folic acid during fetal development. So we tell moms you got to take prenatal vitamins, and one of the main reasons is we want a whopping dose of folic acid in that. I'm going to show you a picture of one of these.
Oh,
Without it, women can have miscarriages or experience preterm labor and preterm birth. And then when the babies are born, they're very low birth weight. This could be a folic acid deficiency. We hear about that stuff all the time. We hear about preterm labor and low birth weight babies on a regular basis. Those are often associated with smoking. A mother that smokes when she's pregnant, guess what? It's also related to folic acid. Scary. We need that. The next one is high levels of homocysteine. Now, that's a kind of a nerdy word. It's kind of an academic or a doctor word. I'm going to explain what homocysteine is here a little bit later. But you cannot have good heart health or brain health with an elevated homocysteine level. It just doesn't work. So not only do you need it in the developing stages of embryonic development, and then right after you're born, you need it when you're 40 and 50 years old in high amounts, because otherwise you're going to get heart disease. Maybe some of these heart attacks that we see happening in men that are in their 40s, sudden cardiac death, or people who need stent placement in their early 40s. Maybe this is an issue with hyperhomocysteinemia I've caught. So I've checked this. I estimated I've checked homocysteine levels probably 2,000 times in the last 10 years on different patients. I check it all the time. It's part, when you come into my office and you need blood work, every single person gets a homocysteine level, every time. It's covered by insurance. It's remarkable that no one's looking at this, or very few people are looking at it. And then finally, folic acid deficiency leads to dementia. It leads to Alzheimer's disease. You got to have high levels. So we're going to talk about what that means. This is the part of my presentation where I got to talk like a doctor. I got to get clinical. I got to talk about the research and look at lab levels. And some of you guys will gloss over and think, oh, he's using big words. I'm sorry. This is the academic part, okay? Folic acid comes in 3 forms, okay? So here's a money slide. You got to understand this. The most common form is the least effective form, and it's called folic acid. This is not what you should focus on. This is not what you should be taking, but this is the most common form in our society. The generic name, I don't even know if I can say it. It's pteroylomonoglutamic acid, and it's actually just folic acid. This is a look at a prenatal vitamin, and you'll see I highlighted this vision right here, this folic acid. I'm highlighting this word. And if you look at the label, it doesn't have the big fancy word. It just says it's folic acid, 1330 micrograms, and it's 220% of the daily recommended amount. So we ask mothers to take a prenatal vitamin that has 200 times the FDA recommendation for folic acid to prevent brain damage in a developing baby. Are you seeing why this is so sneaking important? 200 times. Really, what we should be saying is the dose should be 200 to 2,000 times higher than what the FDA originally said it should be back in the 1940s. That's old data. We need new data, okay? This is the type
years
of folic acid that I recommend with all of my clients, okay? Every single one of my clients, I recommend this form of folic acid, and it's called L-methylfolate. When you look at the label of L-methylfolate, it'll say folate on it, and then down here below, it'll say L-5-methylfolate, and it's a calcium salt. Okay? Now look at this. I'm recommending this is on every one of your roadmaps. And look at this. It's 2,075 times the recommended daily allowance from the FDA. That's a huge dose. The one that over here that we give to pregnant women is 200 times. Okay? We want 2,000 huge doses of it. Okay? And there's a reason this is what I recommend. I'll get into why I'm recommending this. This is a prescription form of folic acid. These two are over the counter. You can go on Amazon and buy both of these. This one over here, called Leucovorin. Leucovorin requires a prescription. And Leucovorin is a 5 milligrams. Look, this 5 milligrams is the exact same dosing as this methylfolate. So this is 2,075 times higher than the FDA recommended dosing. And if you do 10,000 or 10 milligrams, it's 4,000 times higher than the FDA recommended dosing. Well, now you're thinking, why does the FDA recommend such a low dose? And I'm telling you, it's because it was established in 1940 when we didn't understand how important folic acid was. I could prescribe this to any one of you. It would probably be covered by your insurance. And this is 4,000 times the dose. So now you're starting to get a sense of, wow, if I just get a regular multivitamin, it's totally insufficient. Okay? It's just not enough. So, Houston, we have a problem. The problem we have is that this is the most common form of folic acid. And if you read about it, this is what you can just look this up on Google, and this is what it tells you. This pteromonoglutamic acid, or folic acid itself, crosses the blood-brain barrier poorly and very slowly. And it requires the conversion to an active form called 5-methyltetrahydrofolate. That's this supplement right here. This is the one I recommend for all of you. Why? Because your body doesn't have to do anything. This is the active form. You take this and you absorb it right into your brain. But if you use this form of folic acid, it's not absorbed very well. It doesn't get in the brain, and your body has to go through this chemical reaction to convert it to the one I just showed you. It's a synthetic form of folate that needs an enzymatic conversion to 5-methyltetrahydrofolate to be active and usable by the brain. I can't figure out why we're not recommending L-methylfolate to pregnant women. And I did a search using AI. Why don't we do that? And it's because all the studies for the last 30 years have used this form. So we're going to only recommend what we studied, even though we know it's not very effective. You can see it drives me crazy. Okay, why do you need folic acid in the first place? Think of all these things, because that's how you make DNA and RNA. That's how you make it. It requires folic acid. You have billions and billions of methylation reactions in the body. That's why I recommend L-methylfolate. You have to be able to convert homocysteine back to methionine. When you eat a big steak, or you eat a hamburger patty, or you eat beans, there's a lot of methionine. That's an amino acid. And when your body breaks down that amino acid, it gets converted to homocysteine. Well, homocysteine is kind of inflammatory. It creates a problem. Your body needs to convert it back to methionine, and you cannot do that without methylfolate. Okay? Now, we need folic acid because that's how we make red blood cells. It's how we make white blood cells. If you have a deficiency in folic acid, you're going to be anemic and you're going to be sick. Your body won't have a great immune response. Remember, during the COVID pandemic, we were telling everybody, hey, keep your vitamin D levels up. If your vitamin D levels elevated, then you'll have a better immune response. Well, my friends, the same thing happens with folic acid. We need high levels of folic acid to have a good immune response. And if we don't, we get anemic. And we get a condition called macrocytosis. I'm going to show you lab results. I just looked at the labs that I've done in the last 90 days, so the last 3 months, and I did screenshots. I'm going to show you what macrocytosis looks like. I already mentioned fetal neurodevelopment does not happen very effectively without folic acid. People get spina bifida or they have neural tube defects. And if you want to age gracefully and you want to slow down the onset of dementia and not have ADHD and you want to have good focus and you want to have good cognitive functioning, then you need high levels of folic acid. I personally will take folic acid supplements for the rest of my life. I've taken them for 10 years. I will keep taking them forever. So let me talk about the different forms. This is where I get scientific on you, right? So folic acid, this tyrolomonoglutamic acid, it's fully synthetic and it's the most stable form. This is why it's in everything. It's fully oxidized already. So if we put it on a shelf, it doesn't get more oxidized. It's fully oxidized, so it's shelf stable. But it's not very biologically active. It must be converted to L-methylfolate through 4 chemical reactions, and I've outlined them. So this folic acid, step 1, right here at the bottom of your screen. Step 1 is it has to go from folic acid to dihydrofolate. Step 2 is it gets converted to tetrahydrofolate. Step 3 over here, it gets converted to 5,10-methylene tetrahydrofolate. And step 4, it gets converted to 5-methyl tetrahydrofolate. Huge words, I know. So just remember, if you take this form that's in most multivitamins, your body has to go through 4 chemical reactions to get it to the usable form. Or you could just take the usable form in the form of methylfolate. Okay, there it is, MTHFR. And ask yourself this question: how many of you have the genes for MTHFR? Well, if you're a client at A Mind for All Seasons and you've done a roadmap, we tested this. I'm going to show you some of those labs. Okay, so because folic acid is the most stable form, this is how we fortified foods. The FDA knew in the 1940s how important folic acid was. We didn't know how to create other forms of more active, so we started putting this in flour and grains and in cereals, and they're called fortified foods. We fortify them with these folic acid. And if we used like L-methylfolate, or if we used folinic acid or leucovorin, sometimes they would degrade. They don't have a long shelf life. And if you're eating foods like this, cornflakes and Rice Krispies and Frosted Flakes, which I think are all junk food, I do not think these are very healthy. But we've taken these cereals and we fortify them. We put folic acid in them. So look at this. New research is a game changer to push fortified foods in Great Britain. Studies conclude that there's no need for an upper limit on folate, which removes a barrier to mandate fortification that would prevent birth defects. I'm going to translate that. You could take dump truck loads of folic acid and probably not have a side effect. There's no upper threshold of too much. And so there was a worry about this originally because we thought, well, if we put it in foods, what if kids got too much folic acid? Well, now we know they're not. It's not a problem. But I would ask you, don't eat these fortified foods anyway. They're not very healthy for you. We should eat real food, not manufactured foods. And I still think even when we eat real foods, we probably need a folic acid vitamin, especially if there's some sort of a family history of autism or a family history of attention deficit disorder or a family history of dementia. Let's talk about a biologically active form that's over the counter. You can buy it without a prescription. It's called L-methylfolate. And it has a lot of other names. It has 5-MTHF or L5-MTHF or levomethylfolate. It is biologically very active. By the way, folic acid is vitamin B9. It doesn't require any enzymatic conversion to be effective. So this enzymatic conversion that you saw with regular over-the-counter folic acid, now we just take this version right over here in blue. We just take 5-methyl tetrahydrofolate. Okay, so we don't have to worry about that chemical reaction. And the nice thing is this is what will bring down our homocysteine levels. Taking regular folic acid will not lower your homocysteine. And it's not very biologically available, right? Remember, we hear people all the time, people say, well, maybe I'm not absorbing my vitamins. And sometimes I say, well, you're not absorbing them because you take crappy vitamins. If you want to absorb them, take a decent vitamin, take a high quality vitamin that's more biologically available. So what happens if your folic acid level is low and you're 53 like me, right? Well, 52. If that's the case, you're going to want to get your homocysteine level checked. And you're going to want to check your folic acid level. I hope all of you, if you go to your family doctor, that you say to them at your next wellness visit, hey, would you check my homocysteine and folic acid level? Many of your doctors might say, what? I've never even checked homocysteine. It's crazy to me that we don't check that very often. If you have terrible mental health, major depression, or mental illness, folic acid is actually a treatment that has been studied in detail, and the prescription folic acid version is called Serafolin. It has FDA approval for the treatment of major depressive disorder. The problem is Serafolin is poorly covered by your insurance and it costs about $150 a month. Well, you can get it over the counter for 30 bucks a month, right? It's kind of interesting. If you have chronic inflammatory conditions, you might have a low folic acid. If you have poor focus and attention and you need ADHD medicines like Adderall or Vyvanse or Concerta, maybe that's low folic acid. And it's interesting, the deficit in autism and related to folic acid appears to be a language deficit. So some kids with autism are hyperactive and they have poor social skills and they don't make eye contact and learning is delayed and language is delayed. Language is the domain that seems to link back to folic acid deficiency. That's always made me wonder, if I take care of an individual in assisted living that no longer talks, if they're aphasic, I always wonder, well, how long did they have a folic acid deficiency? And if I pound that individual with high levels of folic acid in its active form, will I get some of those language skills back? Because we see it in autism, autistic kids that don't speak, who start high dose folic acid, get their language skills back. I don't know. You never know what happens in dementia. Sometimes we just have to kind of test drive that. And mild cognitive impairment, which leads to dementia, is linked also to folic acid deficiency. Well, I talked to you a little bit about homocysteine levels. Look at this graphic. This is a paper that I found in PubMed that says involvements of hyper levels of homocysteine in neurological disorders. And look at these neurological disorders. They range from things like Alzheimer's and Parkinson's to autism and schizophrenia to major depression and bipolar disorder to vascular dementias and strokes to epilepsy and other forms of neurodegenerative diseases. Those are all linked to homocysteine levels, and homocysteine levels go up when folic acid is deficient, or when you're taking a form of folic acid that's not biologically available and it doesn't get into the brain. Isn't that fascinating? Okay. So the third form of folic acid, remember I've talked about regular over-the-counter folic acid with that big fancy scientific name. And then I talked about L-methylfolate. I'm going to talk about the third version, which is Leucovorin. And Leucovorin is an active folic acid that requires a prescription. Okay? It's already an active form of folate, but it isn't methylated, meaning that this type of folic acid may not lower your homocysteine levels, but it may help with other neurological issues. So it is biologically active and it gets into the brain and it enters the folic acid upstream from L-methylfolate. It's commonly used during chemotherapy or with the use of methotrexate. Now, if you've probably heard of methotrexate. Methotrexate is a biologic agent that is used to treat rheumatoid arthritis. I have a special relationship with methotrexate because my mom has rheumatoid arthritis and she has psoriasis, and my mom takes methotrexate. So you better believe we've got her on high doses of folic acid, because the way methotrexate works is it blocks the conversion of folic acid into the active form. So here's the folic acid gets converted to dihydrofolate, and then it gets converted to tetrahydrofolate, but methotrexate blocks those chemical reactions. So you have this just folic acid, which isn't very biologically available, and it has to be converted to be effective. That's what methotrexate does, so we have to be really careful with that. Okay. Folinic acid also gets into, or leucovorin gets into the cerebral spinal fluid. It is transported into the brain via something called the choroid plexus. That's a part of your brain that takes the lymph and blood and pumps it into the brain. So that's how we get this form of leucovorin into the brain. And it is considered the replacement of choice for a condition called folic acid receptor alpha antibody. Oh my gosh, now I'm really getting technical on you. There's a form of autoimmune disease that blocks a folic acid receptor. And the end result is it causes cerebral folate deficiency. Okay, and there's a whole bunch of risks associated with that. So once again, methotrexate blocks the conversion of folic acid, or blocks other chemotherapeutic agents block folic acid, and people end up with all these terrible symptoms. They get mucositis. Their mouth gets sores. Have you ever known someone that had chemotherapy and they get bad sores in their mouth? That's called oral mucositis, and it's related to folic acid suppression. They get anemic. They get terrible bone marrow suppression. And in fact, there's a term used in cancer called leucovorin. What's it called? I think it's called the leucovorin recovery. And leucovorin recovery is when someone does high dose chemotherapy to kill cancer cells. Then we start giving them huge doses of leucovorin in an IV, trying to replace that folic acid levels because it's all been blocked. Okay. So there's one other type of folic acid called tetrahydrofolate, and it's not used in supplementation because it's too unstable and it's expensive. Sometimes you can find it in certain salts like calcium methyltetrahydrofolate or glucosamine, but it would be more expensive. It's not as biologically active. It still has to have some conversion, so I just didn't talk about it very much. It's not available for commercial use in supplements. So as I wrap up, before I show you some actual labs, I hope I've engendered into you saying, what I'm hoping you're all saying to yourself is, am I taking enough folic acid? Am I taking the active form? What form should I get? Should I go to my doctor and get a prescription for leucovorin, or ask Randy to write me a prescription, or is L-methylfolate okay? Okay, so here we go. Leucovorin is not the final, most active version of folic acid. It's actually L-methylfolate. That's another reason why I recommend L-methylfolate in all of your roadmaps. So you remember these supplements that I talked about in the very beginning. Don't take regular folic acid in a multivite. It's just not effective, and it's too low of dosing. You could get leucovorin over there on the right, but then you need a prescription for it. And the interesting thing is your insurance might help cover it. I've been paying attention to this in assisted living because many residents in assisted living center may not have the money to purchase regular folic acid, but if we can get their doctors to recommend leucovorin, we might get it covered by their pharmacy plan. And MethylPro, or L-methylfolate, MethylPro is just a brand, but it's been my favorite brand because of the dosing of their supplement. And I have looked at thousands of folic or homocysteine levels and followed people after using MethylPro. It's very, very effective. So it's why it's become one of my favorites. You would think they pay me to say that. You would think I have stock in the company. I don't have any disclosures to reveal. I don't get paid by them to talk about it. I've used a lot of different folic acid supplements, and I'll just tell you, it is by far my favorite. Okay, so I created a little table here. If you want to look at the table, what are the conditions all the way around from the general population to if you have MTHFR genetics, or if you take methotrexate, or you have terrible depression. The things that I'm focused on, because I'm a neurological health guy, I'm a brain guy, I'm always focused on mental health issues and dementia risk. So because of those, I recommend these form of folic acid, L-methylfolate or Leucovorin. Those are the more common ones that I do. And so we're going to get to the point in your presentation where I hope you get out your labs and you look for a couple of markers. So today I'm going to show you. I always check folic acid levels. I always check homocysteine levels. I'm going to check something else called MCV, and you'll see what that is here in a minute. And then I check MTHFR genetics. So let's go through a couple of things. And before I do that, cerebral folate deficiency is a neurological condition where you have low levels of folic acid in your brain, in your cerebral spinal fluid. And if you have that, it can be diagnosed through a lumbar puncture or through genetic testing, or you can just look at your serum level of folic acid. And then here's all the potential problems that come with that. I'm not going to spend a lot of time on that. That's kind of an academic. So let's talk about serum folate levels. You have to be able to recognize that when we draw your blood, and I get a test tube full of blood here, and I'm going to check this test tube for folic acid. That is not the same as checking to see how much folic acid is in your brain. We are projecting only that if you have enough in your serum, you probably are getting enough in your brain. And so the same is also true. If your serum levels are low, I guarantee you your brain levels are low. This is why it's so prolific in dementia. This is why you should all get it checked like your vitamin D. Don't make the assumption that you're taking a B vitamin and so you've got enough folic acid, because you've got to have whopping doses of the active version in your bloodstream in order to even get it into your brain. So let me show you some labs, what you should be looking for. The first one is you always look at your actual serum level. The second thing is you're going to look at your MTHFR genetics. Your MTHFR genetics will tell you if you need the active version, because genetically you're not going to convert this over-the-counter version into an active version. Then you need to look at your homocysteine levels, and I want to know what your MCV, your mean corpuscular volume, that level. So let me show you some labs. This first lab is a 76-year-old female in an assisted living center, and she does not talk. She's aphasic. Aphasic means she's lost her ability to speak. Oh, remember, I told you that in autism, the one cognitive function linked to folic acid is language. So I'm always thinking, well, if I have someone who doesn't speak because of their dementia, is it a folic acid problem? I think there's something to be said about that. Now look at this. I checked her folic acid level and it was 7. Oh my gosh, I can't tell you. That is so low. That's brain damage level low. And it's tricky because if you look at the lab, look over here, I've circled. The lab says it just needs to be greater than 3. My friends, that's wrong. Remember, the lab is going off the FDA levels of folic acid. And I showed you that a prenatal vitamin is 200 times the FDA recommended dose. And the recommended dose for neurological issues or mental health is 2,000 times higher. So I always kind of get nauseated when I see a lab say, well, your folic acid only needs to be 3 and it's not even flagged as low. 7.1 is dumpster level low. It's horrible. Okay. And if you look at her homocysteine level, remember I told you we got to look at homocysteine. Homocysteine should be less than 8. And her homocysteine level is 37. Brain damage, cardiovascular damage. This is a major problem. And if you go back and look at her MCV level on her blood count, this is her MCV. Look, it's elevated too. I had a meeting with 14 full-time nurse practitioners and PAs. And I said, when someone's MCV comes back elevated, what do you do? And they say, I give them B12. And I said, you look at folic acid? And they say, no. And I say, why not? Because we didn't know that's caused that. I don't think the average practitioner recognizes that folic acid levels drive elevated MCVs just like B12. If you looked at this lady's MTHFR genetics, here she is, homozygous. That means she has 2 copies of the MTHFR genetics. No wonder it's so low. Her folic acid level is super low, and she can't convert homocysteine back because she has methylation genetics. Well, guess what? When we did her cognitive testing, it was super low. She's aphasic. She can't speak, right? That's the only cognitive test we got. She doesn't talk. Let me give you another one. Here's a 54-year-old female who has a risk for dementia because there's a family history, and she's doing everything she can to try to prevent. We looked at her folic acid level. It was 10. That's too low. It needs to be like 25 or 30. It needs to be super elevated. The next one is her homocysteine level is 6.7. That's actually pretty good. That's a really good. So guess what? She may not need the MTHFR version of it. The next one is her MCV is elevated. This lab did not flag it, but you have to look at the nuance. So MCV here is 100.0, and the reference range is 80 to 100.0. So if she was 100.1, she would have flagged as high. She's high. So even though her homocysteine is okay, MCV is elevated and serum folate is low, she at a minimum needs leucovorin, or she could also use L-methylfolate. And she was positive for the MTHFR genetics. She had it. Okay. So now look at her cognitive testing. At 54 years old, here's her cognitive testing. She scores in the average category, but she's got 5 cognitive domains that are below average. Okay. Attention. Oh, look at that. Her attention span and cognitive flexibility is low. Executive function is low. Working memory and motor speed. Just improving folic acid in this particular individual could change that level. Okay, let's do the next one. Here's an 88-year-old female who has dementia who resides in an assisted living center. I looked at her serum folate level, 4.5. Oh my goodness. Brain damage level low. It's so low. Even look how interesting this. The lab says a low is less than 3.4, but they still flagged it. It's higher than the low reference range, but they still flagged it as being too low. Look at her homocysteine. It should be 6 or 7, and it's 21. Uh-oh, that's a problem. Look at her MCV. Remember, this goes to up to 100.0, and she's at 97.2. It's trending high. And she has MTHFR positive. She's got 1 copy of that gene. So she has the genetic says that she needs the active version. And when Matt Fisher did her MOCA test, she only scored 13 out of 30. Full-on dementia. We're trying to get everything we can to try to improve her cognitive functioning. Here's another one. A 76-year-old female, very proactive, trying to prevent dementia. She lives on her own at home. Look at her folate level. It was greater than 24. I just showed you levels 4.3, 6.1, 7.2. Hers is 3 times that. The lab doesn't tell me what the level is. It just says it's greater than 24. I bet this level is really high. Look at her homocysteine. It's only 8.9. Oh, that's pretty cool. Oh, but her MCV is still very elevated. It's 103. So even though this folic acid level is elevated and her homocysteine level is normal, she may still benefit from a high dose of all the B vitamins, B12, B9, B1, right? And she is positive for 1 copy of the MTHFR variant. When I did her cognitive testing, check this out. 76 years old, and all of her levels are above average. This lady already functions better than the average 76-year-old. Can you see how we're linking those together? She's the only one of the labs that I've showed you where folic acid was pegged through the roof. Homocysteine level was low. She's been supplementing with the right type, and her cognitive tests are fantastic. She's better than the average person. This is what being proactive does to protect your brain. This lady's never going to end up with dementia, I guarantee it. It's 100% preventable in her case. She's going to do fantastic. Okay. Here's another one. Here's a 76-year-old female, also lives at home trying to prevent dementia. Her folate level was 12.9. I think it's still too low. I think it should be in the 20s or the 30s. Her homocysteine was 11. It should be 6 or 7. And guess what? Her MCV is elevated. So all three of these tell me there's some deficiency. We've got to get that level up. And when I looked at her MTHFR genetics, yep, she has one copy of C677T on MTHFR genetics. Look at her cognitive testing. It's not terrible. She's above average in 7 parameters. She's average on 6 parameters, and then she's got some lows over here. So if I go back to her labs, if we increase this folic acid, lower her homocysteine, and optimize her MCV value with all the B vitamins, there's a good chance we can prevent dementia in her, even though she's starting to trend forgetful in some of these areas. Composite memory and verbal memory. Remember, it's linked to verbal. I always thought that was interesting. All right. That was my opportunity to look at some of my clients most recently and try to tie it back to some of the research.